Hello and welcome to today's webinar featuring Summer Bishop. I'm Claire Cameron, Engagement Editor at Spectrum, the home for autism research, news and analysis. We'll begin the presentation in a moment, but first, know that we'll be fielding questions at the end of today's presentation, but you can ask them at any point during the session. To ask a question, submit them via the chat window to the left of your screen. And as always, I'll note if there are any members of the press tuning in, you can only report information presented during this webinar if that material has already been published elsewhere, or if you have first obtained express written permission from the presenter. Summer Bishop joins us today from San Francisco, where she is an associate professor in the Department of Psychiatry and Whale Institute for Neurosciences at the University of California, San Francisco. Prior to coming to UCSF, Bishop completed her PhD at the University of Michigan in Ann Arbor, Michigan. As well as being an associate professor, Bishop is a clinical psychologist at the Services Training, Advocacy and Research Center for Autism Spectrum Disorders and Neurodevelopmental Disorders, which provides comprehensive assessment and treatment services to people of all ages with autism. Her clinical research program is focused on refining, expanding, and combining methods of measurement in clinical and research assessment of autism. She is interested in measurement of social communication and restricted and repetitive behaviors, and how these measurements are affected by contextual, behavioral, and developmental factors. Dr. Bishop has pioneered strategies for separating people with autism into types, an effort essential for pinpointing the molecular risks of the condition. Bishop's work is intended to refine the existing diagnostic and clinical tools to capture the full spectrum of autism traits. Dr. Bishop has received research grants from organizations such as the National Institutes for Health, Health Resources and Services Administration, the Simon Foundation Autism Research Institute, and the Robert Wood Johnson Foundation. Her work is published in various leading autism-focused and general psychiatry journals. Welcome, Dr. Bishop.
Thank you. Well, I'm honored to be here, and I'm excited to share with all of you some of the work that I've been doing with a number of wonderful colleagues over the past couple years. And I'm sorry I have a cough, so this doesn't sound like my usual voice, but I promise it's me. So my talk was originally billed as Advances in Autism Diagnosis, but I've changed it to Challenges in Autism Diagnosis because I think that more accurately reflects what I'm going to be talking about today and really what we have to contend with as a field. So in particular, I'm going to focus on understanding measurement limitations that can hopefully help us to enhance research and clinical practice. I receive royalties from WPS for sales of the ADOS-2, which I will be talking about today in my presentation. All royalties related to my own research, clinical work, or training are donated to charity, and UCSF is aware of this relationship. So just a quick overview of my talk. I'm going to start out talking very briefly about ASD assessment, and I want to mention 3 standardized measures of ASD symptoms that I'll be focusing on today, and then move right into some of the measurement challenges, considerations, and opportunities that I think we are increasingly aware of in our research field. And I'm going to be talking about impact of variables not specific to ASD, so what kinds of things affect measurement of ASD symptoms and how do we need to account for that in clinical practice and research. And then hopefully end on some positive notes about strategies for moving forward despite these measurement challenges. So when it comes to ASD assessment, there's been a historical focus on the development of screening and diagnostic tools so that individuals with ASD can be correctly classified into ASD versus non-ASD groups. And this makes a lot of sense because for clinical purposes, we need to assign appropriate diagnoses to afford access to services. And then in research, we need to have study groups of kids with ASD and appropriate comparison groups. So we have a variety of standardized diagnostic instruments that are designed to assist with this. And this has really been the focus of measurement efforts. But we need to understand how classifications and continuous scores are influenced by different variables so that we're aware, keenly aware really, of what we're measuring. The 3 instruments that I'm going to talk about, the first one is the ADIR, the Autism Diagnostic Interview Revised. And this is a semi-structured parent interview. It takes about 2 to 3 hours to administer. Sensitivities and specificities generally range from 0.7 to 0.9, but most of the studies have been done in terms of the ADI's ability to detect autism rather than broader ASD. And so some recent work suggests that specificities may be slightly lower when we're trying to identify kids who have less severe, less classic autism symptoms. Importantly, the diagnostic algorithms focus on past behaviors, but parents are also asked about current behaviors. The other parent report instrument that I'm going to talk about is the Social Responsiveness Scale 2nd Edition, or the SRS-2. And this, unlike the ADI, which is a semi-structured interview, it's a parent report questionnaire. And it's conceived as a continuous measure of autism symptoms or autistic traits. So it's really more of a dimensional measure rather than a categorical measure, although it does still provide cutoffs that are meant to correspond to likelihood of an ASD diagnosis. And sensitivities and specificities have been reported as high as 0.9 for the SRS and SRS-2, but specificity varies quite a lot by non-ASD population. So as we might expect, specificity tends to be higher in people without any known diagnoses, so typically developing siblings or other individuals from the general population, but it's much lower in children who have other psychiatric concerns, even if they don't have ASD. And then finally, the ADOS, or the ADOS-2, is a clinician-administered direct observation tool, and it's based on coding specific behaviors that are elicited in response to standardized activities presented by a clinician or an examiner. And sensitivities and specificities are generally reported at or above 0.8. So these are three widely used diagnostic instruments, and the first couple studies that I'm going to talk about focus on these measures. So when it comes to the ADI and the SRS and the ADOS-2, as well as many, many other measures that have been designed to assess ASD symptoms, what we've seen in the past decade is a real explosion of use of these measures for a variety of purposes. And they've been extended for use in a broad range of clinical populations and in research populations. And so if we think about the validation samples, when the instruments were originally conceived, some of the more recent populations to which they've been applied may or not be representative of those original validation samples. And so in particular, with DSM-5 and with the ability to diagnose ASD in people with other diagnoses already, the instruments are being applied to these populations to see whether an additional ASD diagnosis is appropriate. So they're being used increasingly in groups with complex behavioral presentations, whether that means psychiatric disorders like mood disorders or thought disorders, or in genetic syndromes that are often associated with very low IQ or other types of problems that the instruments may or may not be equipped to handle. So as I just mentioned, in research in particular, we've seen a huge increase in use of these instruments in rare genetic syndromes. So huge advances have been made in linking specific genetic syndromes and abnormalities to ASD. And so the standardized diagnostic instruments and ASD symptom measures are being used to study relationships between ASD symptoms in these disorders in order to try to understand more about mechanisms that may underlie ASD more broadly as a syndrome. A problem, though, is that a lot of the groups being compared, so even, for example, something like Fragile X versus quote-unquote idiopathic ASD, they often differ significantly on other variables like IQ or behavior problems. So when we're applying these standardized diagnostic instruments and trying to compare genetic syndrome groups to groups of children without known abnormalities, we have to be really careful because the groups differ on things that may affect measurement of ASD symptoms. And this is something that a number of researchers have pointed out before. Vanessa Ball, several years ago, wrote a paper showing that scores on instruments were affected by behavior problems, and we've known for a long time that IQ can affect measurement of ASD symptoms. But as we move increasingly into looking at ASD symptoms in the context of rare genetic syndromes and other kinds of psychiatric disorders, it's important to take a step back and look at the extent to which ASD symptom measures are being influenced by variables not necessarily specific to ASD. So the first study I'm going to talk about was recently published a couple of months ago, and this is work that's led by Alex Havdal, who is a postdoc at the University of Bristol. And we looked at what the influence of individual characteristics was on sensitivity and specificity of the ASD diagnostic instruments that I mentioned, so specifically the ADI, the SRS, and the ADOS. And we looked at how age, language abilities, cognitive functioning, and then emotional behavioral problems measured both by the CBCL, or the Child Behavior Checklist, which is a parent report instrument, as well as the ADOS E-codes, which provides a gross measure of behavior problems as observed during the ADOS, how these factors affected the performance of the individual instruments. So the participants for this study consisted of 225 children with ASD, 168 with non-ASD diagnoses, and all received, as part of the study, all received a standardized ASD assessment that included obviously the SRS, the ADOS, and the ADI, but other measures of cognitive ability, language functioning, and a variety of self and parent report questionnaires to establish non-ASD diagnoses like mood and anxiety disorder. And the clinicians were not only blind to the previous diagnoses of the participants coming into the study, but they were also blind to the algorithm totals and classifications of the standardized diagnostic instruments when they were making their best estimate clinical diagnosis. And so to the extent possible, that's possible, we were trying to separate the scores of the instruments from the best estimate diagnoses. And so the diagnoses of ASD versus non-ASD that you see above were based on the research assessment and not what the participants came into the study with. And here are the demographics. So they were a relatively high-functioning sample overall. There's a lot of variability in IQ, but for the most part, kids were functioning in the average to low average range of cognitive ability. And the sample was primarily a verbal sample. So the ADOS Module 3 is for children who use complex sentences, and the majority in both the ASD and the non-ASD group were using complex sentences. And they were about 7 or 8 on average. So this slide is showing specificity of the instruments by level of IQ. So if you take, this is specificity, this is only the children with the non-ASD diagnoses. But if you look at the SRS, that should read SRS2 moderate cutoff, the ADI ASD cutoff, which is a relaxed cutoff, that is described in Lanehart. It's based on CPA criteria. And then the ADOS-2 ASD cutoff. The specificity in children with intellectual disability was significantly reduced for both parent report instruments, so for the SRS and the ADI. So compared to the children with intellectual disability, with no intellectual disability, those with intellectual disability were much more likely to be captured by the SRS and ADI ASD cutoffs or moderate cutoffs. The ADOS showed relatively balanced sensitivity and specificity, but notably it's a little bit lower than has been reported in other studies, so falling below 0.8 in this sample, regardless of whether the children had intellectual disability or not. If we move to looking at emotional behavioral problems as rated by the parent, so this would be the CBCL, you can see that about half of the ASD and non-ASD samples had either internalizing or externalizing T-scores in the clinical range. And so looking at those who had scores in on the CBCL that were in the clinical versus the non-clinical range, again, the SRS and the ADI showed reduced specificity. So the specificity of 0.45 for the SRS moderate cutoff means that 55% of children with non-ASD diagnoses were being captured by the SRS moderate cutoff, and 40% of children with CBCLs in the clinical range with non-ASD diagnoses were being captured by the ASD cutoff on the ADI. Again, the ADAS shows in this situation relatively balanced regardless of whether the child scored in the CBCL clinical or non-clinical range, but only at 0.77 and 0.75, so lower than has been reported previously. But then we also wanted to look not only at parent-reported behavior problems, but directly observed behavior problems as well. So there's quite a bit of evidence that some of these variables only influence the context in which they're observed. And so we would expect parent-rated behavior problems to affect parent-report instruments. And the question is whether clinician-observed behavior problems would affect clinician-rated social impairments. And so we looked at the ADAS E-codes, which provide a quick and dirty measure of overactivity, disruptive behavior, and anxiety, and compared those who received a total score of 2 on these items versus a score of 0. So 2 indicating that there was some overactivity and or disruptive behavior and or anxiety that was directly observed during the assessment. And what you can see here is that the specificity then on all 3 instruments is reduced as a function of these. And likely when it comes to the parent report instruments, if clinicians are observing behavior problems in this short 45-minute direct observation context, parents are also observing these types of things at home. So it's likely that that they're highly related. Those who are showing the behaviors in the clinical context are also showing behaviors at home. But I think what the important point here is that the ADAS cutoffs or the ADAS classification was affected by whether the clinician had observed behavior problems in that context. So the specificity of the instrument was reduced significantly. Those who showed no or little behavior problems during the assessment, the specificity was 0.83 versus those who showed some behavior problems, specificity was reduced to 0.56. So because both IQ and behavior problems showed similar associations in the ASD and non-ASD groups, reductions in specificity that I just showed you were accompanied by increases in sensitivity. So that means that kids with ASD who had more behavior problems or who had lower IQ were also more likely to meet cutoffs on the instruments, as that was the case also for the children with the non-ASD diagnoses. So what's good about this is that it means that cutoffs could be adjusted to increase diagnostic accuracy of the cutoffs themselves, where you would raise the cutoffs for children with lower IQ or for more behavior problems, and you would be able to achieve more balanced sensitivity and specificity. But then the question is, given how they're employed in a variety of settings, what happens when you're trying to compare continuous scores either within kids with ASD or between groups of children with different diagnoses? So here are just to give you a sense of the continuous scores, and this is the ADI by level of emotional behavior problems, parent-reported emotional behavior problems. And let me see if I can get my arrow thing to work here. Yeah, there it is. Okay, so so what you see is within low parent-rated emotional behavior problems, or within clinical levels of parent-rated emotional behavior problems, we are able to achieve adequate differentiation between those with ASD and those with non-ASD. So we do fine here as long as we're looking within low or within high. But then when you start to compare across, so children with ASD with low parent-rated behavior problems and those with non-ASD diagnoses with high parent-rated behavior problems, we achieve less of a separation. And this is particularly pronounced here with the SRS, where we actually achieve no separation between those with ASD with low parent-rated behavior problems and those with non-ASD diagnoses with high behavior problems. So these children essentially look the same, despite the fact that these 64 have ASD and these 80 have non-ASD diagnoses. You would not know it based on their scores. If you stick to within the low parent-rated EBP or within the high-rated parent-rated EBP groups, you're okay, but looking across the board, we have problems. And then for the ADOS, we are able to, again, achieve better differentiation within the low clinician-observed EBP versus the more marked clinician-observed EBP. Across the board, we still do okay, but it's better within these groups. So from this study, I think it's clear, and other studies that I mentioned too, it's clear that standardized ASD symptom measures, so even those that were designed to assess ASD symptoms, as all three of these were, capture more than just symptoms of ASD. And that's fine. Measures are never going to be 100% pure. But if we overlook these factors that are influencing ASD symptom measurement, we're at risk for drawing incorrect conclusions. And particularly in the neurobiological research realm and genetic syndromes work, I think we are at risk of concluding inflated ASD prevalence rates within syndromes that are associated with low IQ often and high levels of other kinds of behavior problems. And that can lead us to erroneous estimation of biological behavioral associations or the strength of those associations. And then clinically, it's no small issue if we end up with a lot of misdiagnosis because children who are presenting to clinic with other problems that may have less to do with ASD and more to do with either cognitive impairments or behavior problems or other kinds of issues are getting categorized as ASD because they are receiving scores that exceed cutoffs on these widely used instruments. And so just an example of one dilemma that we're seeing a lot in our clinic here, and this is the question of whether a child has ASD or ADHD or both. And we are increasingly, again, I think this is a function of DSM-5, but also just changing trends in referrals and in our understanding of how broad the spectrum can reach. We are getting referred kids who may have already diagnoses of ADHD, and people are considering for the first time whether an additional ASD diagnosis might be appropriate. Or kids who, for whom it's unclear from the beginning whether ASD or ADHD or both diagnoses are appropriate. So we know that ADHD symptoms are present in a significant number of kids with ASD, and interestingly, even under DSM-4, when it was prohibited to diagnose both, about half of kids with ASD had community diagnoses of ADHD. And we also know that children with ADHD have high rates of social difficulties. Not all kids with ADHD, but many, many children with ADHD have social problems. And it's been proposed that for at least a subgroup of these children, that ASD-like symptoms may contribute to their social problems. So now that we are living in a time when we can formally diagnose both disorders, but again, I think when people recognize that comorbidities are real and need to be dealt with, it's important that we figure out where the ADHD spectrum ends and where the ASD one begins. And so and I think that there's been some discussion. People would argue that maybe this doesn't matter because we need to go all dimensional, and it doesn't matter what you call it, whether it's ASD or ADHD or something else. But I would argue that there is value in understanding at least trying to understand when there are true differences and similarities between diagnostic categories, because there are certainly children for whom a clear diagnosis is not attainable, but we have many examples of children who do fit more clearly in one category versus the other, and they would be expected to have different responses to treatment, very different long-term outcomes and predictors of outcome, and importantly, possibly different neurobiology or genetics as a function of their differences in phenotype. So I think even if we're going to think dimensionally, which I'm sure many of us agree is important, it's necessary to understand what we're actually measuring when we're assessing children from these different traditionally defined categories. But that is no easy task at all, and a big problem is that we have to sort out what might be real symptom overlap between different diagnoses and what might be poor instrument specificity. So like I was just talking about a minute ago, if two kids look the same on an instrument, is it because they actually look the same and there's real symptom overlap there, or is the instrument just functioning poorly in terms of specificity in the one population? Another variable that I think that people are increasingly attending to, but still not adequately so, is ascertainment. So I'm going to talk about a few different studies here and come back to the point that how we get these kids, how we get either our ASD kids or our non-ASD kids might really affect how they perform on different instruments. So if you're using a clinically referred sample, you would expect there to potentially be different issues than if you are ascertaining children through a research study or especially through an epidemiologically ascertained sample. And so unfortunately, I don't have any epidemiological data to show you today, but this is something that we need to move towards in this country as well. Other countries are way ahead of us there. So this first study that I'll talk to you about with respect to ADHD is work that's led by Becca Grudzinski, and this was recently published earlier this year. And what we did was look at, participants who had come through a regular clinic referral, and they had, at the end of the day, either ended up with an ADHD diagnosis or an ASD diagnosis. So all of these kids were referred to specialty autism clinics, either at the University of Chicago, University of Michigan Autism and Communication Disorders Center, or the Center for Autism and the Developing Brain. They had all been referred for ASD, but after following a comprehensive assessment, some of the children received an ADHD diagnosis and some of them received an ASD diagnosis. And actually, we pulled out of the existing data bank first the children who had received the ADHD diagnosis, and then the children with ASD were matched to the ADHD kids on age and IQ. So as a result, you can see that the ASD sample has high IQ in the average range in order to match to the ADHD sample, and they are largely a Module 3 sample, so using complex sentences, and a similar percentage of boys. If you look at the percent meeting cutoffs on the ADIR and the ADAS, so the parent interview and the direct observation, you can see that a large percentage of the children with ADHD met the parent report ADI autism cutoff, and then almost 2/3 or more than 2/3 met the ASD cutoff, again as defined by CPA. A smaller percentage, though still a fifth, met the ADAS ASD cutoff, and then not surprisingly, if you required them to meet cutoffs on both instruments, it was a very small percentage, but also your sensitivity over here dropped. So only 60% of the ASD kids met the ADI autism and the ADAS ASD cutoff. And this is just showing the ADAS and the ADI broken down by domain. And I highlighted this because these are current totals. based on the ADI currently reported behaviors, and there's no difference between these ASD referrals who ended up with an ASD diagnosis and the ASD referrals who ended up with an ADHD diagnosis. And that's not surprising because all of these parents were presenting to a clinic and they were concerned about ASD, and so when they're talking about their children's behaviors, they're very concerned about ASD-related behaviors, which is how they ended up there in the first place. We achieve a little bit better separation on the ADI algorithm totals, which are based on past behaviors. But if you look on an individual item level, none of the items that were parent report did a particularly good job of differentiating the ASD group from the ADHD group. And so what we turned to then was looking at the ADOS items to see if we could get some clues from the direct observation about where the ASD kids were really different from the ADHD kids on individual items. And so across the board here you see that the ASD kids are more likely to receive non-zero scores, so to have evidence of impairment on multiple items on the ADOS, which is not surprising because it's designed to be an ASD measure. But as you get into certain types of behaviors like conversation and then quality of interaction, so quality of response, quality of rapport, which is how hard the clinician had to work to maintain a successful social interaction, the kids with a significant proportion of the children with ADHD are receiving non-zero scores on these items as well. So the parent-reported symptoms in this clinically ascertained sample were less reliable differentiators than the directly observed behaviors, and a number of qualitative differences emerged in the direct observation when you look at the individual items, even though the kids with ADHD were still receiving scores on the ADOS and some of them were actually exceeding cutoffs, there may have been, we can assume that there were other clinically important differences that weren't necessarily reflected in the scores, which is what led the clinicians to assign non-ASD diagnoses in the first place. But if you just look at any one behavior, or especially if you're relying primarily on parent report, we see a lot of apparently similar social communication deficits and repetitive behaviors in both ASD and ADHD. Okay, so this is a research sample of participants with ADHD, and this is just to show you that we see a different effect on the parent report instrument, but a similar situation when it comes to the directly observed behavior. So these are participants with ADHD who were recruited specifically for having ADHD, and here they're much less likely to meet ADI algorithm cutoffs than their clinically referred counterparts, which again is not surprising because the parents weren't worried about ASD in the first place. But a similar percentage, about a fifth to a quarter, of the children are meeting ASD cutoffs on the ADOS. And what's interesting here is that we see the same profile of items that are most likely to be elevated. So this is the previous graph that I just showed you, but then I overlaid the research participants on here too. And so we see in conversation, in quality of overtures, in quality of response, in quality of rapport, that both of these ADHD groups are more likely to show elevations on those items as compared to other items. And here's a third sample actually of children with fetal alcohol spectrum disorder, and these were collected a long time ago, but most kids with fetal alcohol spectrum disorder also have ADHD, so it's relevant here. And again, they're showing elevations in their likelihood of scoring on these quality items as opposed to things like eye contact and gestures and directed facial expressions. And when we've looked and tried to separate these out into factors, what we see is that you actually do get a breakdown within the social communication domain between things that might be called more basic social communication, so gestures, eye contact, facial expressions, and shared enjoyment, versus things that are higher level social interaction skills, conversation, quality of social response, reciprocal social communication, and then overall quality of rapport between the child and the examiner. And so here we at least have some clue, and these are not ideal because these are very big constructs here. Even though we're looking item level, there's a lot of reasons that somebody can fall into a non-zero score on quality of social response or on conversation. But the gist here is that we see a beginning of some separation between things that may be more basic, really lower level social communication behaviors that emerge in infancy, and things that are just higher level and harder to put together, and potentially less specific to ASD. And in fact, when you look at these factors and you try to see what's related to scores on them, for basic social communication, only ASD status is related, so whether or not you have ASD. But for interaction quality, as in the first study that I showed you, Alex's paper, ASD status, nonverbal IQ, and behavior problems are all affecting scores on interaction quality. So just to sum up the ADHD and FASD studies, children with ADHD received elevated scores across standardized ASD symptom measures, but the ascertainment method really affected scores on parent report. And I think that this referral issue, ascertainment issue, is really, really important to attend to. Alex Havdahl has another paper that's currently under review where she looked at toddlers whose parents were either concerned or not concerned, and found that the instruments performed quite different, the ADI performed quite differently in children whose parents were concerned about ASD versus those who didn't yet have concern about ASD. So that's something to look at going forward. The two ADHD samples and the FASD sample were similar in terms of clinician-observed impairments, so the types of impairments. They were much more likely to show abnormalities in interaction quality. And I think in general these broad measures of social difficulty are likely to catch many children with non-ASD diagnoses, so these interaction quality measures, just because there are many roads into an impaired score in that area. So we need to further dissect which types of behaviors might be more or less specific to ASD so that we can move towards more refined measures. I think another take-home from these studies is that social problems are not unique to ASD. This is not a news flash, but it's really important to understand. Impairments that differentiate best between groups may provide information about the true essence of ASD, so it's worthwhile to do these types of comparisons. But even more importantly, symptom areas that do not differentiate may represent an opportunity to refine or reorganize into narrower or different dimensions. And certainly we need to prioritize the development of measures to assess dimensions relevant not just to ASD but to neurodevelopmental disorders in general. So non-ASD populations like ADHD or FASD or name your comparison group can provide really critical insights. But I think another big point is that we need to attend more to the relevance of comparison groups for different purposes. So that ADHD group was a relevant comparison for a reasonably high-functioning, high-verbal ability group of kids with ASD, but ADHD would not really be a reasonable control for a nonverbal child with ASD with an IQ of 30. And so thinking about who we're comparing to whom is really important. And along those lines, so I want to move into talking about what we can do differently and how we can move forward despite the problems that we have with influences of non-ASD specific factors on scores on these instruments. So for sure, development of new measures or methods that better account for these variables at the front end is a priority, but we also can apply creative measurement strategies for existing data to glean insights into what other dimensions are important to look at for the development of these new measures. And so I'm going to spend a few minutes, the last part of the talk, on a study that was just accepted last week. And so these are hot off the press data for you. but specifically having to do with this issue of phenotype-genotype studies. So we've had multiple attempts over the last several years to identify associations between behavioral phenotypes and genotypes in ASD. And there are a lot of barriers to this type of research, and from a measurement perspective, because ASD symptoms vary so much within and across individuals as a function of age and cognitive ability, when we try to come up with phenotypic subgroups, we end up being, the subgroup membership ends up being driven largely by cognitive ability and or age. And so it's been hard to sort out meaningful associations, particularly then when we move into genotyping those phenotypic subgroups. So, so the data that I'm going to present come from the Simon Simplex collection. And this is it was a consortium of 12 clinics across North America, and we have children represented in the collection who are 4 to 17 years of age. They all received ASD diagnosis based on rigorous phenotypic assessment, and they all have received whole exome sequencing and microarray, and I think they've all received whole genome sequencing as of a couple months ago too, or most of them have. So Stephen Sanders and colleagues have identified 6 loci and 65 genes associated with ASD with high confidence, and these are primarily de novo loss of function mutations. And when people have tried to look at de novo mutations and their association with phenotypic variables in probands, the majority of evidence for any association comes from phenotypic variables like IQ and sex. So girls and individuals with lower IQ are more likely to have de novo mutations. But there has been little success in associating the de novo mutations with core symptoms of ASD. And so in this paper, what we tried to do was taking lessons about how we know ASD symptom measures are affected by a number of other phenotypic variables, not the least of which is cognitive ability, which has also been associated with de novo mutations. We matched children with a de novo loss of function mutation or de novo CNV in one of these high confidence ASD risk genes or loci, and compared them to, we matched them to children with no detected genetic events. And this is work that was done with a large group, but primarily with Kristen Farmer and Audrey Thurm from NIH. And so the matching strategy, this just shows you, so everybody was in the Simon Simplex collection. Everybody had a diagnosis of ASD. Some kids were missing the genetic data, so they were excluded. And then of everybody who had whole exome sequencing and microarray, we have a group of 112 probands who had de novo loss of function or de novo CNV in one of these quote-unquote high confidence areas, so highly likely to be related to ASD. And they were matched to children who had no such genetic events, and we're going to call them matched autism controls. So they were matched within about 6 months age and 8 nonverbal IQ points. And so as a result, we end up with so this is everybody with no detected genetic events. So this is everybody together. But out of that group came the matched autism controls. And so they're very closely matched then to the high confidence group here. These are the de novo mutation group on age and nonverbal IQ. And then we compared them across a number of phenotypic domains that we think are important to understanding ASD, at least on a clinical level. So cognitive ability, motor skills, language, social communication, and repetitive behaviors, overall ASD symptoms, behavior problems, and then the presence or absence of seizures. And so here's a look at the results. This gray line here is the reference group, so this is thinking about all of Simon's, all of the probands together. And then the dotted line is the group of children with the de novo mutations, and the solid line is their matched counterparts. And what you see is that we get some separation between, after we account for IQ and age and sex, we get some differences between those with the de novo mutations and those without. So in particular, the children with the de novo mutations, so this would be right here, they walked at a much later age than those children who were matched on age and IQ to them. They also have lower, so less severe scores on the parent-reported autism symptoms and on clinician-observed diagnostic certainty. They also show a different language profile. So here, I'm going to show you on this. So here are the matched autism controls. Here's the group of children with the de novo mutations. And so they've been matched on nonverbal IQ. But the kids with the de novo mutation, generally they have a higher nonverbal IQ than the kids without. And they walked at about 16 months instead of about 13 and a half months. And they have a higher, so a better score on the PPVT. So better one-word receptive vocabulary. Less severe parent-reported social communication problems. And then the clinicians were less certain about their ASD diagnosis. And I think this piece is really important because clinicians, when they were making these diagnoses, were completely blind to the genetic status of the participants because they hadn't done the genetic analyses yet. So we can be somewhat confident that these clinicians were actually blind to what the genetic findings would be, and they were rating the children with the de novo mutations as being less certain. They were less certain about the diagnosis. And then also the children with the de novo mutations were more likely to have received Module 3 or 4 of the ADOS, so they had fluent language as opposed to the children without de novo mutation. So 65% of the de novo mutation group received Modules 3 or 4 compared to 51% of the matched group. I'm going to skip this because I know I'm running out of time. Okay, so children with de novo mutation showed less impaired language and social communication generally than those without. And so what this means potentially is that they show a muted symptom profile with regard to language and social communication deficits, despite the fact that they've been classified as having, ASD mutations. And so that means that that as a group, these mutations may not in fact incur specific risk for ASD-related impairment. And we need a lot more work in this area, and it combines a lot of different mutations together. So there are certainly a number of limitations of combining all of the de novo group together and comparing them to the matched controls. But importantly, the group differences in ASD symptoms and language, which haven't been detected previously, were only apparent when they were compared to an appropriately matched group. And so just in conclusion for this paper, considering ASD-related symptoms and behaviors in the context of overall cognitive developmental level is absolutely essential. And if phenotypic variables like IQ that are associated both with genetic variants and scores on behavioral measures aren't appropriately accounted for, then we're going to really shoot ourselves in the foot when we try to link phenotypic profiles to specific genetic findings because we're not going to see them. Okay, so in terms of moving forward from all of this, I think the most important thing that we can all do for each other is recognize the limitations, openly recognize the limitations of current measurement tools and strategies and talk about those and not see it as an impasse, but hopefully figure out creative ways to move around the barriers that our available measurement tools pose. We need to combine different types of measures within and across populations and contexts to identify other key variables that might be important. And then ultimately using trajectories as phenotypes is going to be critical. And we need to think about how relationships between different phenotypic dimensions differ in ASD So taking a profile approach, but how do different relationships between these phenotypic dimensions present in ASD compared to another disorder or syndrome at different points in development? So thank you very much to all of the participating families and the people, the enormous herds of people who helped collect all of the data that I showed today. And then these are the collaborators, my collaborators on the papers that I talked about, and our funding sources. So thank you very much.
Thank you, Dr. Bishop. We have some time for some questions. If we don't get to your question, please know that we will field it to Dr. Bishop via email after this presentation. But one question that we have from the audience today is, in children with a diagnosis of ASD and ADHD, how many appear to have family history of ADHD independent of their ASD diagnosis?
That's a really good question. I actually don't know the answer to that, but I bet somebody does, and maybe even someone on this call, but I can certainly look at that too.
We also had a question of, do the medications that some people take to manage their ADHD symptoms have an effect on standardized autism tests? And is there any research on this that you can point to?
Yeah, so whether when the children are on their ADHD medication, whether they're less likely to score on, you would expect, especially the direct observation ASD measures. Is that the question?
Yes.
Okay, so I think that's a really excellent question, and it hasn't been looked at systematically. We recorded medication use in the study with the research ascertained sample of kids with ADHD. We gave parents instructions to give their children the regular meds before they came to the assessment. So whatever they were taking, we asked them to take before they came, and we're able to look a little bit at the percentage of kids in the different samples who took medication, but we don't have comparisons for the kids within child when they were on versus off their medication. But I think it's a really good question whether you would see differences in scores on any one of these instruments depending on whether the child is on their regular medication.
How do bilingual and cultural considerations come into the challenges that you're seeing in ASD diagnosis?
It's another good question that I think has received relatively little attention. So a number of these measures are translated, but not necessarily validated comprehensively in other languages or other cultures, and so I think that people are starting to do some of that, but there's a question about whether translation does not necessarily equate to cultural validation, and so I don't think we're there yet in being able to highlight all of the remaining questions.
Is there a readily identifiable subgroup of ADHD patients with autistic traits short of a full ASD diagnosis?
So Adriana DiMartino right now has a grant. She's at NYU, and she's looking at children with ADHD with and without autistic traits, and she's using a combination of behavioral assessment methodology and imaging, and trying to figure out some of the neurobiological markers for the children who exhibit more autistic traits. So I think that research is underway, at least by her group and possibly by others, but it's forthcoming.
Do you think that the lack of stratification in measures in ASD with comorbidities is perhaps a contributive factor in children who lose their autism diagnosis over time?
Let's see. I'm trying to understand exactly what the question is. So do kids who have other comorbidities, are they more likely to lose their autism diagnosis?
I think it's to do with the fact that when children lose their autism diagnosis, a high proportion appear to go on to be diagnosed with other things, such as ADHD. And I think the question is trying to get at that, whether or not it was a diagnosis in the first place.
Right. I mean, I think that there are these kids who seem to move in and out of categories like ASD and ADHD, where they might lose an ASD diagnosis and move into ADHD, or the opposite can happen too. But so yes, I think that absolutely the likelihood that you even if you lose your ASD diagnosis, that you might have something else, then increases if you have some of these other comorbid behavior problems. But I think this is where we have limited understanding too, because of a lack of longitudinal work in following kids who start out with one or the other diagnosis and then end up receiving something else. So certainly for the ADHD ASD question, I think the longitudinal work is going to be really, really critical, because there are some longitudinal studies of ADHD that have been ongoing for years, and then some longitudinal studies of ASD, but putting them together in the same study would be really cool, just to see about the differences in outcomes and such that I described earlier as being one of the potential reasons for maintaining categories. Maybe that may or may not hold up when we actually look at the kids over time.
One more question, and then we'll have to wrap up. The diagnosis seems to be mainly based on behavioral and partially genetic tests. Has it been tried whether these conditions can be detected through EEG and other screening tests?
So there are a number of groups that are working to try to combine this kind of behavioral assessment methodology with other biomarkers, and so certainly EEG and eye tracking and lots of other experimental methods have been underway, and some people are reporting various things. And I think that's so right now the clinical diagnosis is based exclusively on behavior, but certainly people recognize the value of using other forms of measurement, and that's clearly where we need to go as a whole field, but combining together different types of measurement and looking at specificity of these different types of measurement across different populations, and then longitudinally to understand what can hold value for different purposes, not just for diagnostic purposes, but also for in terms of prognostic value or subtyping value. So we need to not rely so exclusively on behavioral methodology, but incorporate other things as well.
We actually have time for just one more, and I think it's a good question, so I'm going to field it. What do you recommend to the clinicians whose patients aren't able to get these standardized tools for diagnosis?
Yeah, so that's a really good question and a really complicated one. I think that what we have to do, we have to make sure that clinicians have training not only to be able to administer the tools, but to be able to interpret them responsibly and to interpret whatever they are able to use in the absence of certain standardized tools. So I think standardized instruments have been a wonderful thing for the field as long as people don't become slaves to them. And so for there to be understanding about what we're looking for when we're making an autism diagnosis and using instruments to elicit information relevant to making those diagnoses, but not just completely abiding by whatever a score says. So I think in one way the lack of standardized measures, it forces us to look elsewhere and use other kinds of methods, and hopefully we're all seeking the same kinds of information to make the diagnosis. But for patients, I guess, so that situation would be the case if somebody didn't have if they weren't able to get the coverage for a certain instrument, or if it weren't translated in a particular language. And we have to really work together to make them accessible to people. But even once they are universally accessible to patients, I think it's important to embed them in a sensible clinical diagnostic context where the person who's interpreting the scores really knows what they're doing.
Okay, thank you. I'm afraid that's all we have time for. If your question did not get asked, please know that we will send them to Dr. Bishop, and the replay of the presentation will be available on the Spectrum News site in a couple of days. You'll be able to ask questions at your leisure via the comments box on that page. This webinar is part of an ongoing series, so please check our site for upcoming talks, which will be announced soon, and video archives of previous webinars. Thank you again, Dr. Bishop, and thank you all for tuning in.